Assalamu alaikum wa rahmatullah. Good morning, everybody. It was a pleasure today to be here with you, to share with you some common and something you can face it in your daily life. Okay, we are talking about autoimmune rheumatological disease. You know, it is a multi-system disease, so symptoms and signs the patient can involve any part of your body from up to down. So you need some help as a supportive or confirmatory test to do to diagnose your patient. I know it is very difficult to diagnose from the first or second time, but again, good history and good examination, as all of our colleagues said, you have to do good history and good examination for the patient because it's a multi-system disease. And don't ask for a specific immunological marker if you don't have a provisional diagnosis at your mind. And you will start, of course, with a simple routine investigation as CBC chemistry. Then, according to your lab result and your finding, so you will request of one of these autoimmune antibodies or this immunological test. So we'll start with the ANA. You know, this is the first important one, and it is a common that you are requested. So it is important to request it, and when to request the ANA, and what is the importance of the ANA titer and ANA pattern, and what is the causes of positive ANA. So ANA is detected auto antibodies in the patient. You are expected to have it, autoimmune disease. Actually, it is not intranuclear or antinuclear only. Again, it is a cellular. So the antibodies can be found in the nucleus or in the cells. Most of these antibodies are IgG, but also IgM, IgA can be detected, but less frequently. So as I mentioned, it is not only the antinuclear antibody. You have a lot of antibodies relating to rheumatological disease, and you know that thyroiditis, hepatitis, whatever, a lot of the autoimmune disease can be associated with a positive ANA. Cells, some of this antibody can be inside or outside the cell, extracellular or in multiple locations. But now we are talking about the ANA. Okay, so ANA can be in autoimmune disease, rheumatological or non-rheumatological, or can be found in other, or can you found it positive in other conditions. What is the sensitivity of the ANA? We know that in the systemic lupus, it's from 95, even 98 to 100% of the patient, they will have a positive ANA. And we are mentioning ANA now is a screening for autoimmune disease. So in cases of scleroderma, reaching to 80%. In cases of mixed connective tissue disease and a drug-induced is 100%. So if you find anti-NA negative in this patient, you can exclude these types of disease. And rheumatoid arthritis, which is one of the, we can say for non-rheumatologists, can mimic the lupus. This is a two differential, the common differential. You can find it in our patient with arthritis or general manifestation. Even rheumatoid arthritis, A and B can be positive in 50% of the patient. So this will be misdiagnosed the case. Sjogren syndrome, discoid lupus, which is all skin manifestation, so it present in 15% only, and in cases of juvenile chronic arthritis. What autoimmune disease, but non-rheumatological disease can be associated with positive ANA, we can see here in autoimmune hepatitis and in cases of primary autoimmune cholangitis, 100% of the patients, they have ANA positive. So that's why don't ask for this test, except if you have a clinical finding, you expect the diagnosis. In cases of thyroid autoimmune disease, at Hashimoto's and Graves', it reaches to 50% positive. So what is other causes with not autoimmune disease can present with a positive ANA? The very strong mimics of lupus patient, which is the HIV and the viral infection, TB. So this is mimics of lupus, and you can find the ANA positive also. And there is some association, as in cases of relative of patient with autoimmune disease, you have the ANA positive, and there is some possibility for patient with ANA positive to develop the disease future in their lives. Rarely it can present in cancer patient. So how you can detect the ANA, or what is the ANA test you can perform in the lab? Only briefly, I know this is from the laboratory side, but it is important to know because when you see the result, you will find that the test was done by immunofluorescence or by enzyme linked, which we call it ELISA. So what is the difference between two tests, and you will depend on what of them. In 2010, the ACR, which is American College of Rheumatology, they said the gold standard test to detect the ANA is the immunofluorescence. Why is the immunofluorescence? It will give you the positive test and the titer of the ANA and even the pattern of that. It is a manual technique. It is depend on the man or the human who do it. So it needs a good training and good standardization of the result, and it is a time consuming, but it is the gold standard. So it is it is a microscopic test, so it's done by the one who will do it. The microscope, the slide of the microscope, it will be coated with the antigen, and then they will put the serum from the patient you expect to have the disease, and then you wash the slide. If it is positive, so there will be a reactive anti-antibody reaction, and when you try to wash the slide, it will not be washed. So because the result precipitate of this reaction, and then you will add the immunofluorescence material to that, and it will show you one of the. It is not important to see what is the type, or you can recognize it under the microscope. But this is, we have a speckled homogeneous mixed nuclear centromere and peripheral, and each of one is specific or with each type of the antibody. So by the immunofluorescence, we can see the positive test and the titer of the antigen, and you can see the titer. It is a positive and negative. If it is 1 to 40 or 1 to 80, considered positive. 1 to 40, it will consider a little bit. You have to repeat it again. 1 to 80, this is an important figure to enter the criteria for lupus. Below than 180, even you will enter, the new criteria for lupus now, depend on the positivity of the ANA. So if it is 1/80, it can enter the criteria for that. 1/40, no. If it is 1/160, so this is significant, and you have to look for the type of the anti-nuclear antibody, and then you proceed later. It is, as I mentioned, this is a gold standard, and they are using the what is called HIP2C, which is a highly proliferating cells from the cancerous type of cell, and that it will be used for to detect the antibody. And immunofluorescence, in cases of the ANA, is superior to ELISA. This is a different type of pattern of the ANA, and it's associated with which type of the antibody. Something like speckled is not that specific, so it can present with the lupus, sclerosis, and a lot of disease. But it is important to be, so you will concentrate according to what you see in the slide. You will concentrate what type of antibody you will test more for it. ELISA, it is a confirmatory test, and also it will give you a quantitative number for the specific antigen. So it is not as immunofluorescence, it is human dependent. So this is a micro hole, a plate with a lot of micro hole. Again, they will put the hole are coated with antigen, and in each one of these holes, they will put the serum sample from the patient, and then according to the reactivity, again, antigen-antibody reaction, it will not be washed out, and then they will put a certain dilution according to the dilution the technician did, so he can give you the figure of the concentration of this antigen. What we have the inner profile, usually if you have AN positive, you request for the inner profile. Inner profile include anti-double strand, anti-Smith, anti-Jo, anti-RMB, anti-scleroderma 70, anti-SSA, and SSB, and each one of them, they have a certain character and a certain association with a certain disease. Of course, the double strand, it is for lupus. 50 to 80% in cases of lupus, they are positive, but it can be found in some of the other autoimmune disease, and you know that it is strongly correlated with the disease activity, especially nephritis. So not only at the diagnosis of lupus, but with your follow-up of the patient with lupus, you request for the DNA because it's important in follow-up prognosis, activity, and renal involvement. Anti-Smith is very specific, 99.9%. If you have anti-Smith positive, so this patient lupus, you can confirm your diagnosis. A sensitivity, it is only 25%. That means more than 3/4 of the patient, they will have it negative. But if it is positive, you can diagnose certainly the lupus. And it is not associated with the disease activity, so only done once at the time of diagnosis. RMP, which is the importance of that, it is specific for mixed connective tissue disease. If it is negative, you can exclude the mixed connective tissue disease. And if it is positive, it is associated with high prevalence of renoid phenomena and low prevalence of serious renal involvement. Of course, it found in 30 to 40% of the patient of lupus. Anti-SSA, anti-SSP, it is for Sjogren syndrome, of course, can be associated with lupus and with the other types of the disease, especially liver and celiac disease. And the importance of that in cases of lupus or rheumatoid is the ability of this anti-antibody to detect the placental barrier. So it is the cause of neonatal lupus, whatever serious as a heart block or only neonatal skin lesion. Anti-scleroderma 70, sensitivity is about 34%. 40% of the patient with diffuse scleroderma, they will have it positive. 10% only with limited will have it positive. Specificity is 98 to 99%, 99 point something. So if the patient has a scleroderma positive, so this can diagnose your disease. But if it is negative, of course, you have to look for the other clinical manifestation. And again, as usual, lupus can be associated with positive of almost all types of antibody, but only in 5% of the patient. Anti-Jo, it is specific for inflammatory myositis, dermatomyositis, or polymyositis. Presence of anti-Jo is a bad prognostic sign because of the prevalence of interstitial lung disease with this patient of dermatomyositis or polymyositis. Antihistamine, again, it is a homogeneous. 100% of the patient of drug-induced lupus, they will have a antihistamine positive, and you know some drugs can only cause this antibody to be positive, but other they will have some symptoms of lupus disease, but it is not that severe. And with the stoppage of the medication, everything will return to normal. So this is something important. This is a study, big one, done in 2022. Actually, I put it as a cut and paste, the conclusion of this. If there is possibility to have ANA negative lupus patient, unfortunately, I think no. So look for mimics, look for mimics. They both are mandatory, or there is nothing 100% in medicine, but if you don't ANA negative, so most probably the patient will not have lupus. And you will ask for what type of test you requested for ELISA or immunofluorescence. You can have some suspicion of the technique you did, but ANA negative lupus patient is very, very unlikely. Complement, you know, it is important. It's one of the criteria of lupus. Low complement, it is associated with the patient of lupus, but also with other autoimmune disease, as polyarteritis nodosa and cryoglobulinemia. Apart from rheumatic disease, it can be associated with some infectious disease and glomerulonephritis due to any cause. No need to be related to the autoimmune disease. And it can be low in cases of rheumatoid arthritis, but rarely it is if the patient has extra-articular manifestation. Now, apart from lupus and the other autoimmune disease and the things, now we'll go to the rheumatoid arthritis. The commonest may be autoimmune or inflammatory disease we can face. What we are looking here, rheumatoid factor and anti-CCP. As you know, it is important to take this as mentioned by my colleagues, to detect it early, clinically and immunologically. So we have a rheumatoid factor, which is IgM antibodies, sensitivity 60 to 90% of the patient, specificity 85. In comparison to anti-CCB, specificity is 95%, which is much more than the rheumatoid factors. Again, the best way to detect this is the ELISA technique. As we mentioned, ELISA technique, and it is very important to find the titer of that antibody. And you know that we have to do both, and the patient with both anti-CCB and anti-rheumatoid factor, the prognosis will bad, or can we say the progression of the disease we're expecting to be worse. So condition with a positive rheumatoid factor or positive anti-CCB, again, don't request for that test except if you have a clinical suspicion of the disease, because it's found in some normal, healthy people, especially in the older age group, or even in the healthy young patient, you can find it positive. So if you have found it positive without a clinical sign, you will be into a dilemma. So rheumatoid factor can be positive in non-rheumatic disease. Again, the mimics of autoimmune disease is and tuberculosis and the viral infection. So again, you can find it positive here. There is another disease, malignancy can be, especially in the hematological malignancies. Primary biliary cirrhosis, you have a high incidence of rheumatoid factor. What is about ACPA? Can be positive in active TB again, and chronic obstructive pulmonary disease. So again, TB is our mimics clinically and laboratory. But it is important that anti-CCB will not be positive in patients with hepatitis C. So this can differentiate. What is a rheumatic disease can be associated with a high rheumatoid factor? Of course, rheumatoid arthritis. Number one, Sjogren mixed connective tissue disease. Even lupus in 35 can reach 35% of the patients. They can have a positive rheumatoid factor and other the autoimmune disease. ACPA also can be positive in patients with the lupus and with psoriatic arthritis. So again, it is not that specific or sensitive if you find this antibody. Only a few slides about the ANCA. You know ANCA, we have two types of ANCA, C ANCA and B ANCA, and there is atypical ANCA, which is the third one. And C ANCA, it is targeted the proteinase T, and P ANCA, the myeloperoxidase, the enzyme that is targeted with this antibody. The best test to find this antibody, it is screened by immunofluorescence, and then it is confirmed by ELISA, because you know there is also a fluorescent pattern of this P ANCA and C ANCA. By immunofluorescence, sensitivity reaching to 75%, specificity 93%. ELISA, it is a confirmatory test, and also can give you a target and a specific number. A combination of both, of course, it will be better. You will do ELISA and immunofluorescence, so the sensitivity specificity can reach the 95 to 99%. And it's if you use the test, if you have an emergency, so that one is fast, we will give you a faster result than the other, but both of them can be applied. Again, as mentioned, immunofluorescence, you know, this is important. You know, it is important for our senior and fellow to know this pattern, because it is an exam question to bring for you this type of immunofluorescence. But for you, it is enough to know that what is associated with what. Okay, this slide for the ANCA also can be associated with diseases apart from ANCA-associated vasculitis, the famous three part of ANCA-associated vasculitis, we know it. It can be found in the gastrointestinal disorder, especially inflammatory bowel disease, ulcerative colitis more than Crohn's disease. You can find it positive. In cases of autoimmune hepatitis and again viral hepatitis, you can find ANCA positive. Some infectious, again, tuberculosis and infected endocarditis, again, the mimics of vasculitis, you can find the ANCA positive, and in some drugs and some autoimmune disease as a lupus and rheumatoid arthritis. Okay, so this is, the proteinase is highly specific for Wegener's and the other way around. And again, you can see negative can be seen in both conditions. So again, both a negative test cannot exclude ANCA-associated vasculitis. This is for antiphospholipid, the last thing I will talk about. You know, when to request for the antiphospholipid, this is an indication, you know, recurrent thrombosis, recurrent thrombus at abnormal side, stroke in young, cases of pregnancy loss. criteria for antiphospholipid syndrome, and all patients with lupus supposed to be investigated for possibility of the antiphospholipid. What we are doing, we have 3 major. There is a lot of tests, but this is the one that is done in our labs, and you can find the result. We have a lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein. The lupus anticoagulant, briefly, it is not a direct measurement of the antibody. It is indirect test. Screening test, you have a prolonged BTT. If you have a prolonged BTT in patients, you are expecting to have antiphospholipid syndrome. So this will be a screening test. The other one is the diluted Russell Viper venom. You know what is the Russell Viper? It is a type of snake. They found the venom of this snake can do accelerating the thrombotic events in the in vitro. So if you have this finding, so you will do the mixing study, which is the next step. You will put the same amount of the patient and the normal sample, maybe 1-to-1 proportion, and then if there is correction of the thrombotic or the BTT test, so if it is corrected, so that means the patient has some factor deficiency, coagulation factor deficiency that is corrected by the normal blood U-bot. If it is not corrected, so most probably there is antibody there. So to confirm that, you will add more serum sample, so to overcome the amount of the antibodies present. So the test can be done in this way, and of course you have to exclude other causes of thrombotic events. For the anticardiolipin and beta-glycoprotein, it is used the ELISA as we mentioned. It is only, you will put it in this hole and you will find the titer. And important to have a positive titer more than 40 to diagnose a patient of antiphospholipid, plus clinical finding or the history of the patient. They will give you the result according to their percentile and according to the positive test. So it is a direct. Conclusion, serum rheumatological tests are most helpful for confirming clinical suspecting diagnosis. In general, no single test can diagnose a rheumatic disease. As we said, almost all of the patients, they have some negative result in spite of full clinical picture. In order to increase the utility and decrease the cost effectiveness of the laboratory testing in rheumatic disease, you have to order for the test you need. Allergen combination, clinical background, testing result to provide a good diagnosis of the patient. Thank you.